Thank you, Lars, for those kind comments. Here is the list of my disclosures. Current clinical practice relies on PSA and its derivatives to diagnose and manage prostate cancer. However, we do need new biomarkers to address unmet clinical needs in prostate cancer management, including risk indicators for disease that presents with low PSA values. We also need prognostic markers to distinguish indolent disease from aggressive disease. But today we're here to discuss imaging biomarkers for the metastatic state. The presence of metastatic disease on imaging is a very important prognostic factor affecting therapeutic choices. So, for example, in initial staging, the presence of metastases essentially precludes curative therapy options. And in late-stage disease, the presence of imaging depicted disease helps to define multiple clinical states, including M0, oligometastatic disease, and polymetastatic disease. In oligometastatic disease, we know that there are opportunities to postpone the onset of androgen deprivation therapy by targeted therapy, for example. And in late metastatic disease, we know that the volume, distribution, and response to treatment depicted on imaging are prognostic, affecting future therapy choices. Here, for example, is an analysis published by Susan Halabi showing that there are site-specific differences in survival of men with metastatic disease at different sites. So we can observe that patients with bone and nodal disease seem to survive better than men with liver disease. Data like these may help in treatment decision-making in the design of future clinical trials and help our understanding of the variations that we observe according to the biology, depending on the sites of metastatic disease in patients with castrate-resistant prostate cancer. So the first question we should try to address is whether current imaging tools are fit for purpose, starting with detection. Before we address the issue of imaging, we should talk about how good symptoms and PSA are for depicting the likelihood of metastatic disease. This recent paper shows that symptoms and PSA are not good guides for the absence of metastases, with 32% of patients who were clinically thought to be M0 CRPC who were found to have oligometastatic disease or polymetastatic disease. Here's a patient who was referred to me for a rising PSA following low-dose brachytherapy. The clinical indication was whether he was suitable for salvage radiotherapy for oligometastatic disease. This whole-body MRI scan shows multiple lesions throughout the skeleton. We will discuss this technology shortly. Before looking at this next-generation imaging technology, we need to first think about the current recommendations for using CT scans and bone scans to assess the clinical state and to assess therapy benefits, particularly for bone disease. I would say that these conventional tools are limiting, and we are unable to accurately predict the presence and volume of metastatic disease, which means that metastatic disease detection tends to be late and the volume is often underestimated. So when we think a patient has no metastatic disease, they have oligometastatic disease, and when we think patients have oligometastatic disease, they turn out to have polymetastatic disease. Let's see this in practice. So here's a man who's in a clinical trial with an AR-targeted treatment, And at screening you can see his PSA is raised. We have a whole body MRI scan on the left. This is a special sequence called a diffusion sequence. And we have a bone scan. On the whole body MRI you can see that there are retroperitoneal lymph nodes, no bone metastases are seen, and not surprisingly no bone scan lesions are detected. After 12 weeks of treatment, the retroperitoneal lymph nodes seem to be improving on the whole body MRI scan. No lesions are visible in the bones, and again the bone scan is negative. Now at week 25 we see that the PSA continues to be suppressed, but the whole body MRI scan depicts the presence of one lesion. That's the red arrow. The bone scan is normal. So how do I know that this is a metastatic deposit? The advantage of whole body MRI is that there are multiple sequences through the body, which means that I can zoom in on any particular lesion and look at this lesion with different contrasts. Furthermore, remember that this is a third scan, so I can go back to 2 prior scans and confirm that this is a new metastatic deposit, so this is oligoprogressive disease. The ability of modern imaging technologies to outperform bone scans has been shown by a number of studies, including this prospective study, which showed that whole body MRI had a similar diagnostic accuracy to sodium fluoride PET-CT scans, but finding fewer equivocal lesions, and clearly outperforms both planar bone scans as well as SPECT-CT scans for bone lesion detection. This has also been shown by a number of meta-analyses, including this publication in 2014, where we can see that the test performance of whole body MRI scans is equivalent to fluorocholine PET-CT, and both tests are better than the current standard of care, which is bone scans. Nevertheless, bone scans and CT scans continue to be emphasized as the method for detecting metastatic disease by a number of internationally accepted guidelines, except in 2016 and 2017, we see the increasing acceptance of the use of choline PET scans or PSMA PET scans when evaluating patients for biochemical recurrence after prostatectomy. In 2017, the APCC met in St. Gallen to consider the same question. When the panelists were asked about what they would do to exclude metastatic disease in high-risk patients or those with locally advanced prostate cancer, you see that the majority of panelists would use some sort of next-generation imaging technologies. These are the yellow bars, with a preference for PET scanning. Why did they prefer PET scanning? It's because of better nodal staging by PET-CT. So we can conclude that bone scans and CT scans are not robust enough for ruling in and ruling out the presence of nodal metastases and distant metastases. Clearly, we'd like a single sensitive modality to be able to do both jobs. The best modality is in fact PET-CT, and the tracer depends on what's available to you, with PSMA performing better than choline PET-CT. In our institution, we tend to use whole body MRI to start with and local staging with MRI, because we know that can replace CT scans and bone scans for the presence of bone disease and gross nodal disease. But the depiction of early nodal disease continues to be a problem with this approach. Here, for example, is a patient with biochemical recurrence in whom we see that the choline PET-CT is very effective at depicting the presence of a small left pelvic sidewall lymph nodes in the left internal iliac region. That's the green circle. The whole body MRI scan is poor at this, and although we can see it in retrospect, that left-sided pelvic sidewall lymph node was not called prospectively. On the other hand, the whole body MRI scan is better than the choline PET-CT for depicting metastatic bone disease. So the rib lesion, pointed out with the arrow, is well shown on the MRI scan, but is poorly shown on the PET-CT scan, and in fact wasn't called prospectively. Furthermore, we need to think about how well current imaging tools serve us in the response assessment setting. We know that current imaging has a very limited ability to depict heterogeneity of biological behavior, particularly of bone disease. But we are now increasingly aware that heterogeneity of response is very important for predicting patient outcomes to novel targeted therapies in particular. Another major problem is that we are unable to identify early on which patients are not benefiting from a particular treatment, as a result of which we fail to progress patients through standard therapy so they can become eligible for clinical trials. Again, we need to think about changing the imaging paradigm of patients with advanced prostate cancer. Let me illustrate this to you with the previous patient that we were following. We've already noted at week 25 that the PSA is suppressed and that there is oligoprogressive disease on the whole body MRI scan. But the standard of care, remember, is the bone scan, which is currently normal, so the patient receives 12 more weeks of treatment. After 12 weeks, we notice 2 lesions appearing on the bone scan, and we in fact show 5 bone lesions on the whole body MRI scan. Now, does this constitute progression? The answer to that is no, because in the context of a clinical trial, the patient needs these bone scan lesions to be confirmed, so he receives another 12 weeks of treatment. So at week 49, we confirm polymetastatic bone disease progression on the bone scan, and you can see the PSA is now rising. The actual date of oligoprogressive disease was 25 weeks earlier. And this need to wait to confirm polymetastatic bone disease progression using the Prostate Cancer Working Group criteria before you declare progression, I think results in unacceptable delays before you start the next therapy for this patient. It is against this background that the METRAD standards for whole body MRI scan for advanced prostate cancer were developed. The METRAD standard establishes a way to obtain a comprehensive assessment of the extent of metastatic disease using 2 different types of protocols, one for detection and one for response. The detection protocol for the whole body takes less than 30 minutes on most modern scanners, and these are the sequences that we obtained. For response assessment, we need a little bit more time, and we should be able to do this in about 45 minutes. Here's an example of the comprehensive protocol, which I said would take about 45 minutes. You can see that there are evaluations of the spine and of the body. Various sequences are required, including diffusion-weighted imaging. Your radiologist would be able to recognize these images if you showed this presentation to them. The METRAD system also standardizes data collections that enables detailed reporting of the disease based on the common sites of metastatic spread. It also develops new criteria to assess response of bone disease and summarizes the likelihood of response in bone using the newly developed METRAD criteria, but also within soft tissue disease using the RECIST criteria. So, for example, we have developed criteria on what is likely to represent disease progression and what is highly likely to represent disease progression on imaging criteria that we've known about for many years. So, for example, the unequivocal increase in the number of size of focal lesions constitutes a criterion that indicates highly likely to be progressing. The evolution of a focal lesion to a diffuse neoplastic pattern would also indicate highly likely to be progressing. The appearance of soft tissue disease associated with bone disease is also considered as highly likely to be progressing. Here, for example, is a man who is progressing on maximum androgen blockade. We can see on the morphological T1 sequences, the middle two panels, that there is new disease and that previously noted lesions are larger, and we can see the same thing on the diffusion imaging pair on the right-hand side. You can also see that the patient seems to be progressing in the pelvis with increasing local disease around the bladder, and again, this constitutes disease progression. These imaging findings are reported back to the clinician using images, the standardized text, and the METRADS template. Let's spend a few seconds looking at the template on the right-hand side. You can see that we have divided the patient's body into local regional disease, multiple skeletal and soft tissue sites. And then for each location, we decide whether the region is involved or not. And if it is involved, we assess the primary response assessment category and a secondary response assessment category if that is applicable. The primary response assessment category is based on the dominant response of the lesions in more than half of the lesions within that region. The primary response assessment category is based on the dominant response of more than half of the disease in that region. The secondary response assessment category is on the second most frequent pattern observed. Remember that pattern 4 and pattern 5 represents progression likely and progression highly likely. Responding metastatic disease is assessed in the same way. We look at morphological changes and we look at the changes in diffusion imaging, specifically looking at the ADC value. The ADC, the apparent diffusion coefficient, is a measure of the cellularity of a tissue. An increase in ADC represents cell kill. So an increasing ADC value would indicate response to treatment. These imaging criteria are also incorporated into the METRAD system, with the response assessment category 1 representing highly likely to be responding disease. So, for example, an evolution of a diffuse pattern to a focal pattern would indicate response. A reduction in soft tissue disease associated with the bone disease would also constitute response. But you'll also notice that we have now incorporated the delta ADC into response criteria. So a more than 40% increase in ADC from the baseline value associated with a decrease in signal intensity would be consistent with disease response. Here's an example of a patient being treated with chemotherapy. We can see that in this instance the morphological images show very little change. But if you look at the diffusion weighted sequences, there is a dramatic difference in the signal intensity of the nodes and in the metastatic bone disease, indicative of tumor cell kill. And in this particular instance, the change in the ADC was an increase of about 140%, confirming that this is responding metastatic disease. If we just looked at the morphology, we might have called this stable. So what do the guidelines say about imaging in clinical practice for castrate-naive prostate cancer? the APCC recommends that symptoms and PSA are sufficient monitoring tools for most patients with metastatic castrate-naive prostate cancer, because the proportion of patients developing radiographic progression without a clinical or PSA progression is likely to be small. And indeed, primary resistance should be detectable both clinically and by PSA. So the current recommendation is to use imaging at baseline, at maximal response, or at the end of chemotherapy, and when the patient clinically develops resistance. And this is exactly what we did with this patient. Surrounded by the yellow, you can see a patient's monitored on several occasions while his PSA is rising. And we can see the development of left-sided pelvic sidewall lymph nodes extending into the retroperitoneum, and we also see the development of left groin lymph nodes. This strategy was agreed by the APCC panelists, and you can see the majority of them would choose imaging at baseline, at the nadir of the PSA, or after completion of docetaxel, and at progression. Clearly there are exceptions, and regular imaging is suggested for patients who have oligosecretory disease. And of course there are primary aggressive variants in the castrate-naive prostate cancer setting. And in these patients we would also recommend regular imaging, and this is to minimize exposure to ineffective therapies when disease burdens may be increasing and not reflected clinically or by the PSA. Here's a typical example of somebody who has an aggressive variant prostate cancer. In this particular instance, this patient's on maximum androgen blockade. We can see extraosseous disease, there's evidence of perinephric metastases, there was lymphangitis and pancreatic metastases. But is PSA monitoring the right strategy for patients with castrate-resistant prostate cancer? So in this particular patient, it clearly seems to work. You can see that the PSA rises when the patient is treated with an AR targeting therapy, with the emergence of bone disease, reactivation of the disease in the prostate gland. But we also notice that the metastatic disease within the retroperitoneal lymph nodes goes away, but seems to emerge in the left groin, indicating a differential response to androgen-directed therapy in CRPC. So although symptoms in PSA alone are sometimes recommended as being adequate in the metastatic CRPC setting, it's now increasingly being recognized that these are inadequate. In fact, 20 to 30% of patients can develop radiographic progression without clinical or PSA progression to AR-targeted therapies. And we know that when patients are treated with the alpha emitter, we know that PSA is an ineffective marker for response. As a result of which, multiple guidelines now recommend regular imaging, specifically CT scans and bone scans, when monitoring response of castrate-resistant prostate cancer. Here's an example of a patient in whom symptoms in PSA did not identify disease progression. We can see that he has oligosecretory disease and the PSA does not change. He's completely asymptomatic during this entire period, but he gradually develops cord compression, which you can see on the imaging and not reflected by PSA or his symptoms. And that's why multiple guidelines suggest the use of imaging, regular imaging, for metastatic castrate-resistant prostate cancer therapy monitoring, including the latest EAU guidelines. This is also reflected by the APCC panelists, who would also use regular imaging every 3 to 6 months for monitoring metastatic castrate-resistant prostate cancer. You'll notice that this is quite different to the metastatic castrate-naive prostate cancer setting, where imaging is only recommended on 3 occasions. So what type of imaging should you perform? The recommendations by the guidelines still suggest bone scans and CT scans using in the clinic RECIST criteria and the Prostate Cancer Working Group 2 criteria. That's what the EAU 2017 says. But we now are beginning to think about using next generation imaging. We can see that the majority of the APCC panelists would also use CT scans and bone scans for monitoring response in castrate-resistant prostate cancer. Interestingly, 25% would use a next-generation imaging technology. Why do they do this? Because they are interested in heterogeneity of response, which becomes increasingly common in the castrate-resistant setting. Let me show you an example. Here is a patient being treated with taxane chemotherapy. We can see that the PSA is decreasing, and if we relied on morphological imaging alone and on the PSA, you would call this stable or improving. However, on the diffusion imaging, we can see response heterogeneity. We can see the presence of new liver disease, these are the arrows, despite lowering of the PSA. Not only is it possible to show discordant responses between the bone and the liver, but it is also now possible to show discordant responses within the bone marrow, and this can also be done with diffusion imaging. Now, we don't have time to talk about this novel image processing method, but the important thing for you to realize is that the red areas represent areas where there is no response. The green areas are areas that are highly likely to be responding. So you can see that on the 3rd occasion, there are multiple new red areas emerging, particularly in the right femur. And this is an area of treatment resistance. So if you were going to do a biopsy for the purpose of looking at mutations, then the right hip would be a good area to biopsy. So my recommendation when assessing disease response is to use a modality that assesses cellular viability, and whole body MRI is the preferred economic technique, but colon PET scans would probably do a good job also. PSMA we need to be careful about, particularly in the setting of AR inhibition, so I would not recommend its usage for this purpose, particularly if you're using AR targeted therapies. This is a nice summary slide that shows the advantage of using next generation diagnostics for assessing response to a whole variety of treatments. You can see that the current method of assessing response for bone disease is to say progression and no progression. The introduction of next generation diagnostics enables bone disease to also be assessed in the same way that we currently assess soft tissue disease. In other words, we can identify response, stable, and progressive disease. And this has an impact on how oncologists may think about new therapies and potentially could have implications for precision oncology. So to conclude, we should really stop relying on the bone scan. Next generation imaging technologies such as PET-CT and whole-body MRI scans can detect metastases with much higher sensitivity than bone scans. The early detection of metastases and therapy resistance could have positive therapeutic implications. These next generation imaging technologies can also positively assess therapy benefit, unlike bone scans, which only identify tumor progression. This more accurate method of assessing therapeutic response could aid in the rational development of new targeted therapies. Next generation imaging technologies have not yet been shown to have overall survival benefits in metastatic prostate cancer yet. But we know that bone scans and CT scans do, so we can expect that these new technologies will also show overall survival benefits when they are more widely introduced. Thank you for listening. I'd be happy to take any questions.